It's my absolute pleasure now to welcome Professor Niro Siriwardena, who's made the journey from England to Wales, probably last night, to speak to us. Niro is a key collaborator for the Prime Centre Wales Research Centre. He's an academic general practitioner and also medical director of the East Midlands Ambulance Service. So Niro works in research and clinical practice both at and across the interface that is completely and particularly relevant to our centre here. I won't give more introduction because I think we're getting a little bit short for time. I'll pass you over to Niro straight away. Thank you.
Thank you so much, Helen, and thank you very much to you all for inviting me here today to speak to you. I'm Niro Siriwardena. I'm a GP, an academic. I work with ambulance services in the East Midlands. And thank you also to Adrian, Richard and Joyce as leads of the Prime Centre. It's very exciting for me to be here, and it's a privilege and honour to hear about the work that you're doing and planning to do. I was trying to think about what I'd talk about today, and I'm going to focus on three things: quality, improvement and cooperation, because I think they're pretty central to the work that you're doing. I'd like to talk a little bit about how ambulance services have and can learn from primary care and vice versa in the context of quality indicators and improvement. And I'd like to say a little bit about my journey in terms of the work that we've been doing in England through part of my history. You could say that the desire for improvement is part of my history. My parents came with me and two brothers to England in the early 60s as economic migrants, when that wasn't a rude thing to say. We arrived at a time when people from the Commonwealth were coming here, were welcomed because of the country's needs for workers in health and manufacturing. Sri Lanka is a small island in the Indian Ocean. Some of you may have visited or know about it. It's about the size of Wales, which is the only connection I can think of. Perhaps a little bit more famous for tea and cricketers who are good at spin bowling. We did come over in a boat, and it took about 3 months, I think, to come over through the Suez Canal. I have very little memory of that. But our experiences as a family coming over in the 60s, when we were a relatively well-off family in Sri Lanka. For example, myself and my two brothers all had nannies. Mine was called Elizabeth. But my mum and dad wanted improvement. They wanted to have a different life for themselves than us. And so I guess that's where improvement is in my blood, I guess. They were willing to sacrifice a comfortable bungalow in the tropics, a cook, 3 nannies, a large, extended and often quarrelsome family back in Sri Lanka for an attic here in East London for them and 3 children, all under 5, with a kerosene heater to keep out the cold, working in factories. Definitely no benefits. But also no Race Relations Act. It was more than a decade from the Race Relations Act and 50 years from the Equality Act. So a very different life and time. And improvement through hard work, equity, I think at that time was not part of the language, not a consideration for people coming over. Dad eventually trained as a teacher, and Mum as a nursing assistant, and subsequently became a carer. And even though she's 79, she still yearns after being a carer and would like to go back and do that work. I and my brothers went to university. I studied at Barts and then general practice in Lincoln. It was before the ideas of quality improvement, translation, or even clinical audit were much talked about. At Barts, I remember a renal physician, Bill Cattell, who asks us medical students an important question. He always asks the same question to all of us. What's the commonest cause of death and disease in the community? And we were racking our brains thinking, is it cardiovascular disease? Is it cancer? The answer he was looking for was doctors and drugs. So pretty early on, I began to understand that in terms of the notion of quality and safety, we have great potential as healthcare workers to do great good, but also to create great harm. And some of you may have read the work by Ivan Illich around iatrogenesis and the potential that doctors particularly have for creating harm. When I trained as a GP, I started general practice in 1990 with a new contract, and I spent the next 15 years working as a full-time GP. The care for certain conditions was entirely different at that time. We often used to rush out of our surgery consulting rooms for people with chest pain and suspected heart attack, armed with morphine, sometimes with aspirin, to deliver that to people, and then hung around until the ambulance came, hoping that the patient didn't arrest before the paramedics arrived. So it was a very different time, and care for stroke, heart attack was done primarily with primary care. My doctoral training was in quality improvement before it became fashionable. I did some work around improving flu and pneumococcal vaccination rates, and I'm still working around the area of influenza. I became really interested in the ideas of people like Deming. I heard Don Berwick speak. I met and became friends with a chap called Davis Balistracci, who some of you might have come across, who talks about data sanity and introduced some of the ideas of quality improvement to me, which really fascinated me. I read during my PhD about some of the theories around quality improvement from people like Joe Rycroft Malone, who I think works in Wales. And at around about that time, I also met Adrian and Glyn Elwyn at a conference, and cheekily, as PhD students were then, perhaps they still are now, I went up to them after their talk and said, I really loved your talk. I've got a great idea for a project for you. Would you like to collaborate? And I think it's a good lesson and a marvellous response from Adrian and Glyn that they agreed to do that project that we talked about. And I learnt about shared decision-making and patient experience at that time. So I've run through some of the elements of quality, providing safe, timely, effective, efficient, equitable and patient-centred care. And those are covered in the Institute of Medicine report that some of you might have come across, called Crossing the Quality Chasm. At about that time, I also met Barbara Starfield and heard about her work that Adrian described around primary care. And I think it's important to differentiate between primary care and ambulance service care. I joined an ambulance service by serendipity when I completed my PhD and have continued to work in ambulance services as well as primary care. Primary care, when I started practice, was really the main source of first contact with people, but it's changed, hasn't it, as care's become more fragmented. We have walk-in centres, out-of-hours centres, emergency departments, but actually they're not, and obviously ambulance services, but they're not providing primary care in its true sense. Of course, they provide first contact. There's some coordination involved. But I don't think it's comprehensive and coordinated in the way that primary care fundamentally is. However, the link between the two is becoming ever more important as the health systems are becoming more In terms of improvement, I heard Don Berwick speak a few years back, and he talked about 4 theories of improvement. He said you could just set targets, you could create better markets, add resources to the system, or redesign the system for better performance. And those were the prevailing theories around improvement at that time. And in a way, all of those came into being in some shape or form within the quality and outcomes framework. And many of you know that the quality and outcomes framework, or the QOF, was introduced in 2003-04. And I guess it sort of pandered to the idea that Ken Clarke had when he said famously that he wished doctors would stop feeling for their wallets whenever I mentioned the word reform. So this is a reform that, if you like, subscribed to the idea that if you paid people to do stuff, they would do it, and the QOF might have been partly a response to that. The QOF, involves over 150 indicators supported by computerized data in general practice, but also has other things, templates, prompts, as well as the financial rewards. And a lot of people have worked over the past few years to try and figure out, well, has this system led to improvements in care? And the short answer is possibly, but only a little bit. I think what people have found is that the money side of the QOF, i.e. the injection of £1 billion a year to general practice to achieve these targets, probably didn't do a huge amount. But what did do quite a lot was introduction of the computerized systems, the measurement systems, the templates, the reminders. So that wider system did have a really important effect. And I think we learnt about that when we were trying to set up similar systems in ambulance services. In terms of improvement, I think this reinforces the fact that it probably wasn't the money, it was these other things that were introduced that might have really made the difference. There was some narrowing in differences between socioeconomic class in terms of care provision. And you can see in this chart here that in year 1 of the QOF, the differences between social class 1 and social class 5 practices were considerably narrowed by year 3 of the QOF. So a little bit of narrowing around socioeconomic differences and equity. But the other thing we learned about the quality and outcomes framework in primary care was that commodification of care, or marketisation, this money for performance, came at a price. The price was that continuity of relationship may have worsened, and you'll see that in the quotes here. Perhaps greater fragmentation, perhaps not as much explanation provided to patients as we could have. Suspicion that there might have been gaming, but no evidence of that. But perhaps a more biomedical approach than we needed to provide care at the expense of patient-centeredness and patient experience. So a few years later, I was fortunate to have the opportunity when the ambulance services came together from 34 to 11. Again, just by serendipity, it was agreed that we would start to work together as ambulance services in improvement and in research. I chair the National Ambulance Research Group. One of my colleagues chairs the Quality Group, but we work very closely together and did try and learn what we could from primary care and the indicator system. Around that time, Helen and colleagues did some really nice work around, well, what were the priorities for emergency pre-hospital care in terms of research? And you can see that these were the priorities: performance measures other than response times. And when I joined the ambulance service, paramedics were crying out for 2 things. They said, can't we be measured on something other than arriving at a patient in under 8 minutes. And can't there be better research to inform what we do in pre-hospital care? And so I think this sort of talks to both of those points. Other priorities: pre-hospital clinical management of stroke, safety costs and benefits of alternatives to conveying people to hospital, patient-focused outcomes, and combining information on pre-hospital and patient outcomes in terms of data linkage. And I know that you're doing some of that work here in Prime. So this is a group that came together in terms of the National Clinical Quality Group, and we've continued to meet over the past 8 or 9 years, every 2 months since then, for both research and quality. And what we did was to develop a set of indicators which were smaller. So instead of the 150, which really are too many for people to think about improvement, we developed 20 indicators around the areas of heart attack, cardiac arrest, stroke, diabetes, and asthma. And this is one of the indicators for heart attack or suspected heart attack. Do ambulance services deliver aspirin to people who are having a heart attack? And each blob is an ambulance service, so there are 11 here. This is the population of patients that we are looking at, and this is their performance in percentage terms. And this is a standard funnel plot showing how services are distributed. And you can see one service here which recorded delivering aspirin to 50% of its patients with heart attack, and another service here which delivered 100%. It's interesting, the variation. So we were interested in that, but we were also interested in what the services were doing differently, who were either below or above the control limits of those funnels. When we looked a couple of years later after piloting this, things had improved, but there's still quite a lot of variation. And interestingly, we looked at other issues, and you'll see similar patterns for, say, delivery of GTN for people with chest pain, where the pain scores were recorded, 2 pain scores, and whether morphine or Entonox, i.e. some pain relief, was given to patients with chest pain suspected of heart attack. And you can see each of these actually gradually went a lower in terms of the mean. But if you combine all of those and say, for people with suspected heart attack, are they getting all of the things that we think they should be getting? You can see that the rate is around 40%, i.e. 2 out of 5 patients were getting what we thought they should be getting, which was surprising and a little bit shocking to us. And so, rather than just comparing and benchmarking, our purpose was to try and improve things. And what we did was to work together to share our learning. We mapped out the baseline rates. This is another control chart over time for East Midlands Ambulance Service. And what this shows us that there's a lot of variation over time. So, if you measure something here, and it's 20%, and you measure it here, and it's 60%, we mustn't congratulate ourselves that things are improving. They're not. It's just a random variation over time. And so that's a really important lesson. And instead of just measuring random variation over time, we actually did something about these variations in performance, in quality. And we shared our learning. So you can see that here, this was a meeting, this was sharing of information, and then we started to introduce things like feedback to practitioners, prompts and reminders, and we got significant shifts in care for heart attack for the care bundle. This is one of the other ambulance services. So this was using small tests of change, rapid cycles of change, and sharing our learning across services. We actually led to very significant improvements in care. And the care bundle for heart attack went from 43% to 79% within 18 months, and the care bundle for stroke went from 83% to 96% over that same period of time. So fantastic improvements. There was no money attached to these improvements at all. So the funding part of the QOF was not introduced for ambulance services. We just shared learning. We cooperated. We focused on improvement and quality. So I'm going to just finish by talking a little bit about future opportunities for research. I think what's happened here in Prime is very exciting. I'm very envious of the collaboration that you have and the work that you're doing, and you've got a great opportunity. There's some work that's already happened in terms of pathways between primary, pre-hospital and the acute sector. So the work, for example, that Helen Snooks has done on falls through the SAFER studies. There's work on pathways. I realise that you're now doing on TIAs, led by Nigel Rees, which is very exciting. There's similar studies going on in the northeast of England. They always have food names. It's the pasta trial going on. I can't remember what that stands for. We're doing some work around the hypoglycemia pathway in the East Midlands. So people with hypoglycemia due to diabetes. We know that if you get hypoglycemia, that you've got a 10% risk of getting a further attack of hypoglycemia within the next couple of weeks. And a lot of these people are taken off to hospital when actually if you could intervene earlier, there's great opportunities for preventing hospitalisation and the harms associated with that. There's similar work that can be done around epilepsy. We know that novel interventions are being developed. For example, there's been a fantastic trial around external cardiac compression devices, the paramedic trial, which I think has won Trial of the Year recently. There's the Airways trial at the moment comparing different airway devices for cardiac arrest. We're learning in ambulance services something that is surprising, how to randomise patients in the back of an ambulance and how to consent people and assent them to take part in a study, in the rapid sort of emergency setting of an ambulance. We're doing a trial of GTN, that's a nitroglycerin patch for hyperacute stroke in these Midlands. And of course there's the wider organisational work that you're able to do now with the collaboration that you have at Prime around indicators, around things like variation in conveyance. There's some work that's proposed which we hope is going to be funded around electronic records in ambulance services. So I think it's a great opportunity for you, and I'm very excited at the prospects for your sort of future work and learning. I just want to end with a quote from Bobby Kennedy, and the great task for us is to confront this poverty of satisfaction, purpose, dignity that afflicts us all. We seem to have surrendered personal excellence and community values in mere accumulation of material things. And I think the values around excellence and community that Prime offers is something to be commended, and I look forward to your progress with great interest. So thank you very much indeed.